Hello, everyone, and welcome to Rare à l'écoute, the podcast channel dedicated to rare diseases. Today, we are discussing Cushing syndrome, and to talk about it, we are pleased to welcome Professor Olivier Chabre. Professor Chabre, you are an endocrinologist, a university professor at the Grenoble Faculty of Medicine, and a hospital practitioner in the endocrinology diabetology department of the Grenoble University Hospital. You are also responsible for the Competence Center for Rare Pituitary Diseases. So, Professor Chabre, my first question is quite simple. What are the clinical signs and symptoms that should suggest a Cushing syndrome?
It is the most important question for clinicians that are implicated with this patient. Cushing syndrome has many signs, but most of these signs are non-specific, which makes the diagnosis difficult because this patient may have abdominal obesity, hypertension, diabetes, and this looks very much like a much more common condition, which is called metabolic syndrome. So one should focus on the specific signs of Cushing syndrome, which are mostly catabolic signs, which means that the skin is going to be atrophic, and you can have bruises or stretches in younger people. You are going to develop amyotrophy and osteoporosis. Also, the obesity has a special form, which is, we call it develop in the upper part of the body. The patient have a round face, which is also a red face, which can help think about this syndrome. Cushing syndrome is a rare disease, but actually not so rare if you consider that all patients who are taking corticoids, glucocorticoids, all develop Cushing syndrome, which is only the side effects of glucocorticoid. And most physicians know well what are the signs that are linked to glucocorticoid. So you have to think that Cushing syndrome is just like a patient who is on corticoid. He has a round face, he has catabolic signs on the skin, the muscles, and he can have osteoporosis, and this helps differentiate him from patients with metabolic syndrome. The fact that almost no signs are specific means that many patients are going to have a long delay before the diagnosis. It is estimated that this delay can be 5 years, and it is called the wandering diagnosis. So one should really think about the specific signs to raise the question, does my patient have Cushing syndrome?
So we can face symptoms that are not very specific and could be shared with more common conditions. To confirm the diagnosis, what are the first-line examination a physician should perform?
Once you have reached the first step, which is the question, does my patient have Cushing syndrome? Is he making too much cortisol? Many physicians are going to measure cortisol level in the morning. And actually, this is a very, very bad idea, and one should learn not to measure cortisol in the morning. This may seem paradoxical. Why shouldn't I measure cortisol if I think my patient is making too much cortisol? Well, the fact is that most patients with Cushing syndrome will have a normal cortisol levels in the blood in the morning. How can that be? Well, it's very simple. A patient who doesn't have Cushing syndrome has a cortisol which is at its maximal level in the morning, and then it's only going to decrease in the afternoon, and it's going to be very low in the evening. Whereas a patient with Cushing syndrome is going to have cortisol that is going to stay at levels around the level that it has in the morning, which means the morning is really the worst moment to measure cortisol because it's the only moment where you can miss the patient. So the first thing is do not measure cortisol in the blood in the morning. So what should you measure? There are 3 first-line diagnosis tools that you can use. The first one is to measure cortisol in the urine, in a collection of urine of 24 hours. And this is a very good exam because it reflects the average levels of free cortisol in the blood. The only difficulty is that the patient should be reliable in collecting all his urine for 24 hours. Then you can measure cortisol in the evening, but of course you cannot send the patient to a laboratory and you don't want to hospitalize him only for measuring the cortisol. You can actually measure the cortisol in the saliva, and the patient is going to do himself a sampling of saliva, which is going to be sent to the laboratory. And this works very well. It will show that in the evening, the patient with Cushing syndrome has much higher level than a normal patient. And the third tool is a test which is not difficult to perform. It's called a suppression test with 1 milligram dexamethasone. You're going to prescribe to a patient 1 milligram dexamethasone, and he's going to take them in the evening at 11 or midnight, and he's going to have his cortisol measured in the blood the next morning at 8 a.m. And a patient with hypercortisolism, with Cushing syndrome, is not going to have a low cortisol in the morning, whereas a patient who does not have Cushing syndrome will have suppressed level to very low level of cortisol in the morning. And this is a very good test. It's not difficult to perform, and it's very reliable. So these are three tests. You can use only one at first, and if it's not normal, you can go forward with a diagnosis. If it's normal, if you still think that the patient may have hypercortisolism, you can use another test, and if this other test is normal, then you stop. But with the use of these three tests, and if you remember not to use cortisol in the morning, then you should identify which of your patients with a metabolic syndrome plus catabolic signs does indeed have Cushing syndrome.
And then, Professor Chabre, when hypercortisolism has been confirmed, how to identify its origin?
So the next step, when you're sure that the patient has hypercortisolism, is to find out whether it's an adrenal disease or if it's related to a tumoral secretion of ACTH. If it's an adrenal disease, in most cases it's a tumor in one adrenal, mostly benign tumors. Well, the pituitary is normal, and it's going to suppress its secretion of ACTH because the pituitary is going to see that there is too much cortisol. So you're going to have a low ACTH. Whereas if you have a tumor in the pituitary, which is the case in most cases, or outside of the pituitary, which secretes ACTH, the ACTH is not going to be low. You have to take attention to the fact that the ACTH is not always going to be elevated. It can be normal, but normal level of ACTH are inappropriate if cortisol is too high. So to distinguish between an adrenal disease and an ACTH-dependent disease, you just measure ACTH. If it's low, you have ACTH-independent Cushing syndrome, which is an adrenal disease. If it's normal or high, you have ACTH-dependent hypercortisolism, which in most cases is pituitary, but can rarely be a tumor that secretes ACTH, which is not in the pituitary. So, how do you distinguish between these two cases of ACTH-dependent Cushing syndrome? Well, you first have imaging, MRI imaging of the pituitary, or CT scan imaging of the abdomen and the thorax. The problem is that even if you have a pituitary tumor, which is the case in most cases, you're not going always to see it at MRI. Even the best modern MRI are going to miss around 30% of the patient because they can have very small microadenoma or adenoma that don't have a signal different from the normal pituitary. So in some case, you're not going to find out where is the tumor just by imaging. So you do have dynamic tests that are a little difficult to explain and which can give evidence for mostly tumor which is in the pituitary versus outside of the pituitary. And in difficult case, you will have to use a complicated exam, which is called bilateral inferior petrosal sinus sampling, in which you're going to measure the ACTH level in the venous blood just outside of the pituitary. And if you see that in this petrosal sinus the ACTH is higher than in a peripheral vein, you have demonstrated that the tumoral secretion of ACTH does come from the pituitary, even if you don't see the adenoma on MRI. And this is very important because it will allow you to treat a patient as a patient who does have a tumor in the pituitary.
And now, Professor Chabre, if the origin is indeed pituitary, which is the most common case, what kind of treatments can we propose to patients?
Having a tumor in the pituitary with Cushing syndrome, it's around 80% of all cause of Cushing syndrome. And we do advocate, like most specialized teams, that the patient be operated by an expert neurosurgeon who is going to perform transsphenoidal surgery, which is not a heavy surgery for the patient. It's a very specialized surgery, of course. It does not have a lot of risk. And the efficiency rate with an expert neurosurgeon is around 80%. And in our team, we have shown that even when you do not see the pituitary tumor at MRI, because it is so small, an expert neurosurgeon can cure the patient in 75% of the case, which makes pituitary surgery the most efficient treatment for patients with Cushing disease, which is the name when you do have the tumor in the pituitary. If the surgery is not a success, or if you cannot operate the patient, which is not very common, you do have medical alternative, mostly using drugs that can either inhibit adrenal secretion of cortisol or try to inhibit ACTH secretion by the adenoma. There are several drugs. They do have some efficiency. They do also have side effects. We believe that this should be reserved for the patient who are not cured by surgery, pituitary surgery, who cannot be operated right away. And finally, in very difficult case, when you cannot treat the patient, well, when the pituitary surgery was a failure, and if you have difficulty with the treatment, the last treatment that you can do is very efficient. It's called bilateral adrenalectomy. You're going to remove both adrenal. This works always, but the patient now have adrenal insufficiency, which is another disease that he will carry on forever. So it's a difficult decision that we reserve only for the very difficult case.
Well, thank you very much, Professor Chabre, for all this clear information on Cushing syndrome. As for us, dear listeners, we thank you for your time, and we look forward to seeing you on our podcast channel for a future episode on Cushing syndrome. See you soon.